Okay, thank you for those who are attending. So this is a webinar. It was one of our deliverables to Health Canada, as already mentioned, that we were very keen to present. One of the numerous projects that was funded under the Health Canada funding agreement from 2021 was funding a couple of projects relevant to palliative sedation with a view to potentially moving towards practice guidelines, recommendations, which we're not part of this, but maybe in our future. Today, we're going to have two presentations for projects that were funded and supported by Health Canada. So thank you very much to Health Canada. Our first presentation will be from Bruno Gagnon, talking about experience of palliative sedation and some essentially cohort reporting of a large cohort of people who receive palliative sedation in Quebec. So practice aspects of their practice and reasons for getting palliative sedation. And we also have Henrique, who's going to be presenting an umbrella review on palliative sedation and guidelines and aspects of guidelines. And hopefully we'll have time for all of that, plus questions, and we'll laugh and we'll cry, but mostly we'll learn. Is there anything else we need to say before we get started? Any housekeeping, Fiona?
Not that I know of, no.
All right, fantastico. So in that case, I will, I guess, hand the microphone over to Bruno. Bruno, would you like to get us started?
Yes, I'm doing that now. Let me try to get rid of that. Okay, I have no conflicts of interest to declare. And this was, as you know, funded by the Health Canada grant. So, as you know, palliative sedation is indicated for physical, psychological, existential distress. And as we know, it's cause for major discomfort. So what we do when it's refractory. So we have to recognize that sometimes we have failure on other means. And we have to look at risk benefits, and then we go for palliative sedation. We use the definition of monitor use of medication to induce decrease of awareness. So you all know about that, so we'll go fast. As you know, from our umbrella review, we found that 15 to 18% of patients are getting palliative sedation, but it's highly variable and it tends to increase over time, over the years. So, sorry for my French corrections. So what we wanted to do is to look at the practice and outcome of continuous palliative sedation in Quebec. So is multi-setting, and in fact, is a population based, but with some limitation. I did that. So we took advantage of the End of Life Care Act of 2014 that made the reporting mandatory of the use of continuous palliative sedation until death. And there was also some guideline produced by the College of Physicians in Quebec at the same time. And this is it, palliative sedation at the end of life. So this is the form of reporting. I will not go in details, but just to know that the methodology was to extract the available information from those forms that are filled by the team, mainly the palliative care physician or the physician, after the end of palliative sedation, so at the time of death. So it's not necessarily the person, the physician who started palliative sedation, and we have no way to know the quality of the reporting. So it's really based on physician consciousness to do it well or not. We did not make any attempt to go back to the chart because this was impossible for the numbers of cases, and it was outside the methodology we decided to take. So the objective is to describe the demographic and clinical characteristic of patients receiving palliative sedation in Quebec, and to examine variability in clinical practice across diagnosis, indication, and care setting. So it was a convenient sample of more or less 1,005 patients. So it was two of the 4 university hospitals that was included, 3 of the regional healthcare service institutions. So just to know that in Quebec, before this study started, so before 2016, there was reorganization of the healthcare system in Quebec, where regional hospital, chronic care institution, and home care services had been merged together with 13 regional healthcare services, resulting of this merge. So that's why you have regional hospital, chronic care institutions, some palliative care, inpatient services, and home care. There is 32 hospices in Quebec, and we surveyed 3. So it was very convenient, but we tried to reach different variability on the settings. So 45% were from academic hospitals, 39 from hospices, and 16% from regional hospitals. So as expected, almost 80% were cancer, but we have some cardiovascular disease, respiratory disease, infection, neurodegenerative disease, and others. Older people, and 50 as male and female. So the most frequent indication was existential distress, 57%, but most patients have 2 or more indication. So you can see this, that the psychological distress was the big one, with respiratory pain and delirium after that. So the way to read that you have all these numbers, meaning the multiple indication. But here you can see that we had 188 patients who had palliative sedation for only psychological existential distress, and 62 for pain, and 122 just for respiratory distress. Time of sedation or on sedation tend to be longer in academic hospitals, more than twice in median time, and more or less equal in hospice and regional hospital. Here is to show the difference between people who had a component of existential distress versus those who did not. So in blue, you have those who did not have existential distress, and in orange, you have the one who had existential distress. And as you can see, as the time on sedation increase, you have more increased percentage of patients receiving longer sedation if they're having existential distress, and this was significant. In fact, everything is significant because of the number of patients. Most of, so 94% of the outcome of the sedation was complete relief. There was some incomplete relief, so they were not able to really completely relieve symptoms of the patient, and we had complications. Most of them were respiratory distress and with or not secretion. And we had 3 cases of patients with pulmonary edema. So what is particular in Quebec is methotrexate is very is used almost in all cases. Okay, so and most of the time is midazolam. Scopolamine is regularly used. Lorazepam is a good drug also used. I was surprised by the number of phenobarbital. Phenobarbital is quite huge, and the others, propafenol, compromise, were occasional. So, as with the indication, the use of medication were multiple in different patients, more than one. And the problem with the data collection, it was impossible to know, for example, if a patient started on lorazepam and was moved to midazolam, or from midazolam and moved to propafenol, for example, of phenobarbitals. So they were not necessarily receiving all those drugs at the same time. It was impossible to know in details. This is an aperçu, a way to see the dosage. This by 24 hours is not necessarily the reality, because the way we decided to do the calculation is to take the prescribed dose, because that was reported in the form, and put the dosage in 24 hours. So patient may not have received this dosage necessarily if they were switched or they changed the medication in the over time, or they die within the first 24 hours or the first 48 hours or whatsoever. But in general, the dosage are keeping with the recommendations. So cancer patients tend to have been more on midazolam or lorazepam and receiving methotrexate. The cancer were not less likely to have propafenol, and this is highly significant. And psychological distress or existential distress, they were receiving more methotrexate and lorazepam. Hospice tend to use more lorazepam, midazolam, and phenobarbital. My suspicion from the experience in practice in Quebec is very difficult to prescribe phenobarbital in an hospital bed that is not the ICU. While in hospice, I suspect that the team are more used. They are a close team and they are used to work together to be able to give phenobarbital in their patients. So in general, this is a large study, multi-siting. We believe that even if it's a convenient sample, we're close to the reality at the population level. Still more use in cancer patients. We're surprised in a way for the percentage of existential distress as the sole indication for palliative sedation. And the medication use is consistent with the Quebec guidelines. And there was very low numbers of patients sedated less than 2 days. Was it underreported? It could be, because patient may have died during the night and so on, and no physician at the time to form the form, fill the form. But we have to remember that physicians were paid to fill the form, so there was an incentive to report palliative sedation, a financial incentive. So that's it. I'm open to questions, discussion, etc.
Justin, see your hand.
Hi. Hi everybody. Thanks, Bruno. That was really interesting. As a new person to Quebec still in the last 4 years, it really I find this data very interesting and raises lots of questions. Um, One question I remember Henrique, we chatted briefly about this, I think, when we saw each other last. I'm curious, what is our sense of like differential rates of treatment for existential anxiety in Quebec compared to other places? Do we have that data?
Well, we cannot. I don't remember. Let me check. Do you remember, James?
We don't have it for other parts of the country. So this is one of the nice things about this that, sort of Bill 52, often known as the MAID law, but in fact, it created a whole bunch of important sort of reporting regulations. And, as a result of that, Quebec has like a really nice fleshed out set of palliative sedation guidelines and a standardized reporting form. So like it's like I actually think it's unique in the world is the only part of the world where palliative sedation is a reportable event and a mandatory reporting form must be filled out. Although I imagine that not just most of the time when people do sort of PRN only sedation that wouldn't get reported. So it's probably like capital S sedation, not little s sedation. But I mean the numbers are pretty impressive. I found it shocking to see how common palliative sedation was provided for existential distress, given the MAID rates as high as they are in Quebec, and the fact that the number one cause of MAID is existential distress. To see that there's still this huge swath of people getting it for existential distress, which, according to EAPC guidelines, or at least what most guidelines suggest, is it either shouldn't happen or should be an exceptional situation.
Yeah, so I think the question that keeps coming up for me in being here is I keep wondering whose existential distress we're treating with all of this palliative sedation. I do think that we treat clinician provider existential distress a lot with the use of this approach, but that's just editorial.
Well, obviously, our data cannot show that, but the fact that you have a fair number of patients that have prolonged sedation when they have only psychological distress, that it's not the same patients than the other ones when they identify. So there is something unique in this population because they tend to have a longer time. So they're not completely at the end of life like the other cases. Yes, Henrique.
Oh, I'm having a lot of problems with the technical end of this, the Zoom meeting. Anyway, I didn't know whether you could hear me or see me. So I agree with Justin. Whose discomfort are we treating? And how is it determined the existential discomfort that's being treated with sedation? My experience of accompanying 3 people to the end of their lives, my in-laws and my husband, was that they weren't consulted about being sedated. Neither were we, the families. And I went to nursing school 30 years ago, and we were taught that it was standard practice to sedate dying patients, and it wasn't something that was really that there was protocol about. And sometimes the nurses felt that often the end of lives were being reached faster through the sedation. So it's something I'm very skeptical about. I have a mentor, Dr. Patch Adams, and he believes in the fun death, which is the equivalent to what the PCPC-RC would believe is a good death. And I think we're taking away people's experience. I think we're severe, and it's a large problem that I question. I don't have the answers. I'm just These are just queries and thoughts that I have. And I know that when I'm in my husband's position, I'd like to be conscious if I can be. If I'm not in terrible pain, I want to be conscious. I want to go out interacting with my loved ones because it's a natural event. And why are we controlling? Why is it being controlled the way that it's being controlled? I don't know if this offers anything up that
Well,
you haven't
in
thought
this,
of. Anyway,
in this data set, there was a reporting of if there was discussion with the family, how the family were doing with, or how they felt with the palliative sedation. And most of them, more than 90% of them, of patients did have input from the family in this data set. So family are involved
I'm not sure that
in
they're
this
aware of what's
reporting,
happening.
I mean.
Okay, yeah. Okay, but maybe they're not fully informed of what the alternatives are and why it's being done. And I wonder if they're fully conscious.
So, Andre, I would love to follow up on that point if I can. There are other hands up, and we have another presentation.
Yes,
So
please.
maybe I'd like to put a pin in that because I think you really illustrated one of the reasons why it is so important to have you and the other patient and family partners on these meetings because your perspective on this is quite different than many of ours, as well as you've reading in the chat. Henrique's comment about patients and family members desiring a RAS-PAL of -500. And so it's very interesting. But Pippa, I think your hand is up as well.
Please carry on.
Okay, so there was some, before we go to the other question, just so all the definition of peaceful death, indication, existential distress, and so on, is self-reported by the physician. There was no criteria to how it was done, but we have to remember that 90%, I suspect, or even more, are done by palliative care physician. So we have to hope that they're well trained to know how to define existential and psychological distress. So anyway, all those definitions are based or defined by the physician themselves. So there was no set of criteria to be able to define psychological distress. So the clinical diagnosis.
So thanks, Bruno. My question is just about whether there was any documentation of what treatments had been tried for existential distress, and I suspect not. But I couldn't read the small print on the big form there.
We had no, we decided not to go to the chart because the archivists were not, we could not get the support of the archivists because it was too complicated because patients were dead and so on. And there was a place where they could write what was done before the starting of the sedation. And unfortunately, very few physicians had written anything in this box. So we could not consider this data because it was less than 10% of physicians who took the trouble to really write something.
And Olivia, your hand is up as well.
Yes. So I was part of of the study, and I want to say that. Sorry, sometimes my English leaves. I want to say that before Law 2, it was really rare that we sedated people for essential distress. I remember one case, and we talked about it for weeks in the team. But since Law 2 appeared, and I don't know either if it's because all the anti-cancer treatment became so complex, and I feel that the symptomatology of patients is much more complex than it was before. But we see it much more. And oftentimes it's people who ask for MAID, but they become non-eligible, and the distress is huge. And we get to And there's not, it's really difficult. And sometimes we try psychology and other medication, ketamine. It's not because we want to sedate people, but they ask for it really fast, and family ask for it really fast. And they really want a RAS -5. And the distress is huge until they're completely sedated. So I think it's not only doctors and physicians, I think it's a sociological shift in the good death and suffering. I don't know.
Thank you for that, Olivia. I think it is really interesting how much the focus has shifted to existential distress since the arrival of MAID in Canada. I don't know if other jurisdictions are finding the same thing. And again, I'll just echo my points as well. I think it would be really interesting to your point, Pippa, to dig deeper into understanding a bit more about the existential distress. I don't think we expected to see that many cases. Like I thought I thought it would be like a sort of rounding error number. But to see it as like number one is kind of like surprising to me.
I think to get deep into this, it would require a qualitative approach with multiple like cases where people are actually interviewed, and you could probably get to the bottom of it with relatively small numbers of patients with a deep dive with them individually.
Justin's volunteering to do an ethnography.
It's just we're back to what I was saying to James. We forgot to present one paper that we did do, qualitative study interviewing physician, nurses, and so involved, social worker involved in palliative sedation across Canada, and see how they felt about what is their understanding and so on. So maybe another day we could present the result of the qualitative study. Or you can go and look at it, Bruno Gagnon, and read it. And we have found interesting things. And still physician or some of the responders think that palliative sedation is low-made. Okay, there's still this opinion around in the health, in the team doing palliative care.
This is obviously very interesting. I think we can continue this. I wonder, would it be time to pivot to the second presentation, and then we will almost certainly have more discussion time as well to come back to this, because I think there's a bit in there about that sort of tangentially touches on some of the things we're discussing here. So Henrique, are you okay to load up yours, and then we'll come back to this important point?
Thank you for your attention, everybody.
Thank you for presenting that, Bruno, and for all the work that went into finishing it. It was published, as you know, and very, very interesting addition to the literature.
Bruno, I will share. Yeah, there it is. So we'll pivot a little bit. This part is a little bit less exciting, just because it's a review, and there's no particularly different findings as we had with the first part, but it's interesting to see the tangential points like James mentioned. I have nothing to declare. Of course, this was funded by the same grant. So just as a preamble, we know, and that's something that we started with, practices are varied in terms of the indications and even the terminology that we use to talk about palliative sedation. And there's always ethical concerns about the practice and how it distincts itself from MAID, and the proportionality and the intent and principle of double effect, all of that. So this is something that we go into the review with already. And then the objective of the review was to map the current evidence to inform eventually a Canadian guideline on this. And the methodology was to look into the 5 W's: who, what, when, where, and why, plus an H for how, that was already published in reviews. So that's what an umbrella review stands for. Most of you know this. It's a review of reviews. So what we did was getting all the reviews related to the palliative sedation topic in that period there from 19 to 24, and extracted data from them by doing just a double screen and double extraction, and this resolved the disagreements by consensus. We used AmStar. AmStar is a tool to evaluate the quality of systematic reviews. The quality was reasonably good for most of the studies, but you will see that we didn't have a lot of, well, we had some, but not the majority of the studies were systematic reviews per se, so they are not AmStar eligible. So we didn't have many results for that. I wonder if that's a question or just maybe just an unmuted microphone. So those are the variables that we collected from the studies, and I will show you a little bit of results, just a summary from all of them soon. So this is what we found. This is the Prisma that we developed. We started from a 3,500 study list, and then after some screening, we ended up with 49 studies that were included in the review. Those 49 studies are, of course, all reviews, and they look like this. So 35% of them were systematic reviews, proper systematic reviews. And then the others were also proper studies, but not systematic reviews per se, so not AmStar eligible. And then literature reviews, some more overviews, qualitative synthesis, and other types of reviews. And those we can't get specific data on quality, but we got a lot of information from all of them. A lot of this comes from Europe. I wonder, that's just personal, what's the word? Personal idea about this. I wonder if it's just because the APC did a lot of work with palliative sedation before, and that's probably why Europe has a lot of studies on palliative sedation. But then North America and Asia, as usual, distributed there. This is just the main author nationality for the studies. But the meat starts to appear here. Sorry, my screen is odd. I can't see the whole slide. Now I can see the whole slide. Sorry. So regarding the definition, so the first W, the what. So most of the reviews would emphasize something in those lines: relieve intolerable suffering from refractory symptoms by reducing the conscience. That's something that we actually could get some consistency, but very different wording. Significantly different wording from different countries, from different settings. The word terminal appears quite frequently. Sometimes there's nothing about terminal. Sometimes there's nothing about intolerable suffering, but just suffering, or there's no gradation. So it's very inconsistent, the actual terminology used to talk about this. And what we hypothesize there is that this helps, or makes it worse, makes guidelines more imprecise for a consistent clinical and ethical application. Just using our discussion from maybe 10 minutes ago, if we don't define what's a peaceful death, how can we study this? How can we say that everybody will have a peaceful death, or X% had a peaceful death, if it's in the eye of the beholder? So that's a little bit of a problem that we also noticed from reviewing the reviews. Who gets it and how frequently is it? Also very different. It's very different between different sites, very different in between different countries. But clearly the overall rates increased over time in the European studies. Initially, more cancer for sure, but we can see there a lot of cardiovascular patients, REST patients, neuro patients. There's other patients mentioned as also not only eligible, but getting it. So it's everywhere now in terms of diagnosis. And in terms of who receives it, if we look at the ones that we actually have numbers, patients that receive palliative sedation tend to be a little bit younger, a little bit more frequently males, and a little bit more frequent in the oncology population. But otherwise, everything is kind of similar between groups there in terms of recipients of sedation. Then the other W is about where and when, of course. So it is done everywhere. In terms of care setting, this is done everywhere in all those reviews. Wards, ICUs, palliative care units, hospices, long-term care, even at home. There's some questions raised by few studies when it's done at home, when it's done in the community, about the complexities and the bureaucracies doing it, but it's also mentioned that it's something that can be done there. It is, if you interpret the terminology in all the different reviews, the life-limiting disease, or the idea of being imminently fatal, is there for the majority of the studies. So that's the when idea, but in a very broad sense. And if you go to time under sedation, it is very varied, as you can see in the little box. It varies from 19 hours to 12.6 days. And if we go look at the previous study, the one with the Quebec data, there's patients sedated for just a couple hours. But on average, this would go in all the reviews from 19 hours to almost 2 weeks. So clearly very different patients and very different indications. Many guidelines suggest that patients should have hours to days prognosis, but this is not consistent across all guidelines. But the hours to days discourse also appears quite frequently, and it connects with the idea of imminently fatal, life-limiting disease. So why being our indication, our refractory symptom that guided the indication? The refractory word appears in pretty much all of the reviews, and that's why we are treating. And the vast majority are physical symptoms. That is the part that I think there's some more interesting meat on this review. Delirium or agitation, pain, and dyspnea, very common physical symptoms. Pretty much all the studies mention that sedation is sometimes used for those. Also, some other physical symptoms, less frequently mentioned, but nausea, vomiting, seizures, bleeding also appear there sometimes. But the interesting part is the part there on the right on your slide, non-physical symptoms. The fear appears in a couple, and the psychoexistential distress with different wordings, but the psychoexistential distress is something that appeared as a reason to sedate in several of the reviews. Interestingly, and it matches what we just said when we were discussing the other study, this appears more frequently in the more recent literature. And when you look at the guidelines and the reviews that reviewed guidelines, the endorsement is very inconsistent across those guidelines. When they mention existential distress, they would preface it that it's in very specific circumstances, or they would simply not even mention existential distress and just talk about the physical symptoms. And there's a couple of them that actually advised against sedation as a treatment for existential distress. So clearly, to use a very research-prone term, more research is needed, because there's no clarity from all those reviews about when is it appropriate for existential distress, with people saying do it, people saying, oh, do it, but only in specific circumstances, and people not even running from talking about this. Also something we discussed before, about the how, but there's a few hows here. The how in terms of decision-making and how we decide to do this. Every paper mentions the need for a comprehensive assessment and for multidisciplinary consultation. So this is common across the board. So that's an easy one to say that there is some consensus and there's some clear guide to use. Palliative care expertise is emphasized, as palliative care specialists being the professionals that are actually able to do palliative sedation and to indicate palliative sedation correctly. And the need for informed consent, or at least surrogate from family or POA consent, is required. But the word generally is operational here, because it's not consistent across all the papers, all the reviews. Family involvement is common and mentioned in most of the studies, but not all, and always as family participating either in the consent process or participating in assessing the patient level of comfort. And it appears both here in the decision making, but also on the monitoring part a little bit further ahead. Talking about the other how, the actual more practical how, medications, midazolam is definitely the most common, usually through a continuous infusion, with some alternatives mentioned, levomepromazine, phenobarbital, or propofol. Those are mentioned. Other drugs appear every here and there. Painfully, there's morphine mentioned in one of those reviews, and morphine is not a sedative, so it shouldn't be there, but it appeared there. But on average, those three are the ones that commonly appear. And they mentioned too that you should continue both opioids and antipsychotics if the patient has pain, dyspnea, or delirium, respectively. So if the patient is already on an opioid dose, you continue that because the pain and the dyspnea are still symptoms that occur for those patients. And antipsychotics, if the patient is delirious, particularly if the patient is agitated, then you would continue while you add sedation to this mix. Or sometimes you would drive sedation with a more sedating antipsychotic, but you continue on the antipsychotic train because these patients would benefit from that. So risks, what's mentioned about risks there is not particularly common, except for the survival impact. The survival impact is discussed quite a bit in those reviews, but there's also the more clinical risks mentioned in a few papers here and there, mostly talking about decreased respiratory drive and paradoxical agitation with benzos. And since we use midazolam as the first line, that would be something to worry about. It appeared, just doing a crossover with the other study, it appeared very rarely in the Quebec group, but it's a risk. It's a theoretical risk that can appear. But the important thing was that is not necessarily important, but what appears more consistently is the risk of a negative survival impact. If you look at the Cochrane review that was quite recent and had a lot of data, there is no survival impact overall. However, as all reviews like that, there's many caveats. The evidence, the numbers are limited. The reports are quite heterogeneous in terms of quality, and there's no real randomized trial to prove that. But if you look at the numbers that we do have, there is no actual survival impact based on those numbers. The quality of the evidence is the problem there. It's a little bit on the iffy side. Another part that I think has some meat for this review is the ethics part. Everybody talks about intent, proportionality, and the need for safeguards. But what appeared more recently in those reviews is the need for a distinction from MAID. And then there's several arguments for that. One of these arguments is the idea of proximate intent. So relieve suffering is the real intent. So it would be different than MAID. The objective is not to end someone's life. On the other hand, it's just to relieve the suffering. And you would enter into the realm that, well, if existential suffering is real suffering, then you could relieve it with this treatment. There are also the idea that we always would use proportional dosing with palliative sedation. So the objective is really only to keep the consciousness down, and not to really end the patient's life. So the proportional dosing, it appears there as something that would make palliative sedation a distinct procedure. Of course, the definition of success is not dying, but success is symptom relief. What else is there important? The double effect concept that is invoked very frequently to justify this foreseen but unintended life-shortening effect. So yes, maybe there's some life shortening with sedation. However, that was never our intent. So it's acceptable. It's morally, ethically acceptable. So There are challenges with this moral distinction. A few papers mentioned that intent can be ambiguous, and sedation and stopping hydration would likely hasten death at some point. So the intent is one, but we are still doing things that would very likely shorten life. So this makes it a little bit more hazy to do the differentiation, the distinction from it. So the guidelines mentioned that recommend clarity around the intent, but still there's the problem with double effect. So even if the intent is the best, we'll risk there is some kind of life shortening. So what can we see from these reviews? Palliative sedation is increasing. Then this is very clear from the more recent reviews. If you compare the rates, the practices vary wildly, and the word is wild, not widely, because there's things very different between different places. As the definitions of the terminology, the way people talk about sedation is also very different. Existential suffering is currently not generally supported by those reviews, those guidelines, but it's appearing more frequently as a discussion topic, and it's something that we will need to tackle at some point. Midazolam is the first line, and monitoring and documentation practices vary a lot, but everybody mentions at least the need to document the reasoning to start sedation and the consent process with surrogate and or patient, and that's it. What we are thinking that we probably should keep as priorities is that we'll need clearer guidelines on how to do this, and stronger communication recommendations regarding how you explain this to families, like Andrea was mentioning, how this is being talked about with patients and families is probably suboptimal. We don't have good evidence to say that, but practice shows that it might be suboptimal. And of course, enhanced training and a lot of training and discussion is needed around the ethical part, particularly this distinction from mate. I think that's pretty much it. Yes, just thinking about guideline updates, those are items that we would suggest that we probably would need to work on to get guidelines updated or new guidelines written. But those are not from the reviews. Those are just our interpretations and our suggestions that we could use based on everything that we read from those papers. I think I can stop right here, and maybe we have some time. We do have a little bit of time for some discussion. I don't see any hands yet, but please, guys, let's chat about this. Thank you.
Thanks so much, Henrique. Questions? Thanks to Justin for posting that infographic.
Andrea has
Yeah.
her.
Oh, sorry,
Well,
Andrea, go ahead.
I have a comment. I don't think you're suggesting that by withholding hydration, that's a good practice to hasten death, that hastens death. What I was told that, like my husband, he needed to be as comfortable as he could be. He needed to be hydrated. So I'm just wondering, hydration seems important in the death process. I don't know if that's true or not. That's the question.
That's a very good question. That some people studied. There's actually a randomized trial that was stopped early because what they found during that trial was a trial from MD Anderson many years ago when I was a fellow, that showed that there was really no difference. Actually, maybe the people that got more hydrated, that got a liter a day, were a little worse. But that's one study, so we can't really say anything from that. Definitely, some patients will need some degree of hydration. Some patients will actually have a worse death with hydration. If we think about the heart failure patients, for example, hydration tends to be a little detrimental for those patients. But there is still no good evidence to show if it's great, good or bad, really.
I wonder if there's less palliative sedation in home deaths for existential distress than there is on hospital births? A question that I was just wondering.
It's a good point. It's why I don't think we have this number, but it would be very nice to see. It's probably, I would say it's probably less, but
Yeah, because we didn't the denominator, I guess, in any of these studies, I don't think we know like what proportion of deaths in a region are palliative sedation. These are more collections of palliative sedation, and we're sort of inferring what they are. I wonder, like, it would be theoretically possible to do a bit of a comparison by like region and center. But it would be, I think, quite confounded. I think it's fair to say, Andre, that that what you're saying is correct. Like, I think palliative sedation in general would be much more common among hospitalized deaths than among community deaths. But I think that would be confounded by the fact that they're not the same. Generally speaking, the complexity of the cases is quite different. So what's happening in hospital would tend to be more symptomatic individuals. Would they be? And then, if you're in terms of competition, like, are you too busy being sedated for your pain that you don't have time to be sedated for your existential distress? I guess it would be one way of looking at it as well. Sorry, Bruno, did you want to say something?
No, I just want to say that I was very surprised that in the Quebec data we had 0 sedation at home, and we have in Quebec good home care programs with the full team, physician, nurses, social worker, and so on, and we had no sedation at home. And we did look in home sedation. It was possible. If they were, we will have access to them. So there was 0 sedation at home. I was very surprised.
Do you think that was a lack of reporting, or is that a reflection of performance?
No, I don't think it's a lack of reporting. I think first, they tend, when the patient become unstable, they tend to send them to either back to the hospital or to palliative care unit or hospices. And I think the access to MAID that changed things. One patient are deteriorating, very often the MAID is the solution that is chosen more than sedation at home because it's more simple. It's quite demanding.
Sorry guys, it's Genevieve. I'm in the car and I can't raise my hand without making some dangerous moves. So James, you need to come and spend time with RPCT, because anybody saying the patients are less complex in the home is they haven't spent a lot of time with me. Not kidding, but I think it's relatively common, but I think it just depends to how you define palliative sedation. Again, we do, I think, in all settings, a lot of sort of lighter sedation for sure, just with medications we use. I don't have a large caseload right now because of other priorities, but we did 2 cases of like true palliative sedation in the last, I would say, 2 months. So it's not infrequent or rare. And I don't know what the difference would be between Ontario and Quebec and other jurisdictions, but I can't say that it's a rare occurrence in the Ottawa area. Probably not as often as hospital settings.
No, I want to be clear. I was obviously trying to trigger you with my comments, but I was more to the point. I think I was I think it's more on the whole. I certainly appreciate that there are a lot of palliative sedation procedures performed in the home setting. As a percentage, I would guess it's lower than the hospitals.
I would say so.
Yeah.
And I just wanted to respond a little bit to the comments, because I think language is really important here, just around hydration and hastening death, and interventions that are aimed at prolonging life. When we stop them, we're not usually referring as hastening death. we're really referring as stopping a life-prolonging intervention. I think it's very different than an intervention that will shorten life as opposed to stopping something that is aimed at prolonging life. And I think it's an important distinction for the public to be aware of.
And I just want to make another comment on the experience in Quebec that may explain why at home there is no reported sedation. Is in Quebec is almost a universal procedure to prescribe respiratory or major events distress protocol, which include the use of scopolamine, morphine, and midazolam to be repeated as needed. So in fact, there is a professor who is in nursing who had studied that in chronic care institution, and her conclusion is that respiratory or major events distress protocol are used, in fact, almost as a sedation, palliative sedation approach. So there is an underreporting of sedation.
I think people, it's to the point, I think the scenario when most people consider it and think about it, and I think would fill out a form, isn't in a situation when there's an acute event and you're sort of like, you've been rapidly escalating and then you suddenly institute this and the person dies in a matter of hours, versus somebody sitting down, having a good think about it and deciding that we're going to initiate this. And I think, Andre, to your point as well, I think a lot of the time there are people that do things that, you know, like there's sort of, when talking to the residents, I talk about sort of three scenarios of sedation. One's where an agitated person, you're just trying to calm them down. One is a person where you're giving them pain medications and they get sedated as a side effect. And this is an entirely different situation than both of those, where you're deliberately, you've got a symptom that you can't manage with the thing that's supposed to manage it, and you're trying to make them unconscious so that they're not suffering from that symptom. And that's there's sort of what often happens, I think, in other contexts is you're maybe simply trying to treat agitation and overshooting, which can look a lot like sedation, even without necessarily intending to sedate them. And a lot of the time, it may be escalating doses of symptom management medications, which cause sedation as a side effect. And physicians, well, to any family member, you would look at that and say, they're sedating my dad, or they're sedating my partner. Docs are like, no, we're not. No, we're using morphine. Or no, we're just giving Haldol for the agitated delirium. That's not sedation. And so it's very much a sort of definitional thing that we get hung up on, that people, to Bruno's point, like it's underreporting, but some people probably wouldn't even think of that off the top of their head as being sedation. Whereas to all the rest of the world, anyone in the rest of the world, it would look obviously like sedation. Yeah, that one too. These are all like super interesting comments and discussions. And I think, Andre, you highlight the point that I think a lot of us in practice, like I get this a lot where I do start palliative sedation. We have a big conversation. We're starting palliative sedation. And we actually did a study of something called dexmedetomidine, which the big upside of dexmedetomidine is that it was supposed to calm people down without necessarily sedating them. And this brilliant drug, which we've been using for years in the ICU, and it's fantastic and it saves lives and everyone loves it. And so why not bring it into the palliative care environment where it will also perfectly sedate, get people to stop being agitated, but perfectly calm and interactive. And it was a total failure. It worked extremely well to achieve the goals of the drug. The drug did exactly what the drug was supposed to, but a remarkable number of patients and families, in very narrow situations, it worked extremely well. The families were super happy, but very often what you produced was somebody who was kind of they weren't agitated, they weren't sedated, but they weren't themselves. And that was actually really distressing for families to see. And not infrequently, the families requested that we stop the study so that we could just sedate them down. So again, it's a question really, I think, of having a good conversation with family members, because the goals may be very different for some people than others. I think the my experience is more often to have family members who are concerned that the person may be under sedated and they want them more sedated. And sometimes they will outright ask if there's anything we can do to speed it up. And we say no, of course, but that's highlights the fact that they really, for them, they're not looking necessarily to preserve time and interactivity at that point, that they just want they want to remove all doubt that their loved one might be comfortable, or all doubt that their loved one might be experiencing distress. It's a tough one. It's really hard, and you're sort of talking around this in circular terms often, which doesn't make it easier. I don't know if there are any other questions. We are at time, but I want to thank very much Bruno and Henrique for their presentations, presenting some of this great work. Obviously, big thanks to Health Canada for funding these projects that will hopefully lead to ultimately not only a better understanding, but ultimately maybe some guidelines for practice here in Canada that are a bit more robust than what currently exists. And then hopefully down the road, maybe some quality improvement work will come from this. Thank you very much to all of you for attending and for interacting and for your comments, because I think that's a really key part of all of this. And for those of you who are at the end of your day, have a great evening. And if you're not at your end of your day, I hope you get there soon.
Thank you, everyone.
Bye.